Good morning, everyone. Today's topic is approach to GI bleeding. Gastrointestinal bleeding presents either overt or occult bleeding. Overt gastrointestinal bleeding is manifested by hematemesis, like vomiters of red blood or coffee grounds material, melena, black tarry stools, and hematochezia, or passage of red or maroon blood from the rectum. Occult GI bleed may present with symptoms like blood loss or anemia, with symptoms like lightheadedness, syncope, angina, or dyspnea, or with iron deficiency anemia or a positive fecal occult blood test on routine testing. So we should be able to differentiate between overt and occult GI bleeding depending on the presentation of the patient. Gastrointestinal bleeding is characterized by the site of bleeding depending on the ligament of Treves. Above that ligament of Treves, it is called as upper GI bleeding. From esophagus, stomach, and duodenum, it is upper GI bleeding, and below the ligament of Treves, it is lower GI bleeding, which is from colon, small intestine, or obscure GI bleeding. In this image, we can see upper GI bleeding and the lower GI bleeding and small intestinal bleedings. In upper GI bleedings, we can see malarious gastric ulcers, duodenal ulcers, esophageal varices, and hemorrhagic gastritis. And in small intestinal bleeding, we can see ischemic bowel diseases, intersusception, and Meckel's diverticulum. And lower GI bleeding, we can see colonic carcinoma, rectosigmoid carcinoma. Most commonly, we see hemorrhoids, anal fissure, and diverticulosis and inflammatory bowel disease. Sources of gastrointestinal bleeding. Peptic ulcers are the most common cause of upper GI bleeding. Approximately 20% of patients with bleeding ulcers have the highest risk findings of active bleeding or a non-bleeding visible vessel. One third of such patients have further bleeding that requires urgent surgery if they are treated conservatively. In this image, we can see endoscopic stigmata of bleeding peptic ulcer classified as high risk or low risk. In this, we can see grade 1A, that is spurt blood, and in grade 1B, we can see oozing of blood from the ulcer, peptic ulcer, and in grade 2A, we can see non-bleeding visible vessel, and grade 2B, adherent clot, we can see, and in grade 2C, we can see flat pigmented spot, and grade 3, we can see clean base of peptic ulcer. Prevention of recurrent bleeding focuses on three main factors in ulcer pathogenesis. That is Helicobacter pylori infection, non-steroidal anti-inflammatory drugs, that is NSAID usage, and acid. Eradication of H. pylori in patients with bleeding ulcers decreases rebleeding rates to less than 5%. And if a bleeding ulcer develops in a patient taking NSAIDs, the NSAIDs should be discontinued. And if NSAIDs should be given, must be given, so we can use a COX-2 selective NSAID plus a proton pump inhibitor to treat the patient. Patients with known cardiovascular disease who develop bleeding ulcers while taking low dose aspirin for secondary prevention should restart the aspirin as soon as possible after the bleeding stops, that is after 1 to 7 days. And aspirin should be discontinued in most patients taking aspirin for primary prevention of cardiovascular event who develop upper GI bleeding. And patients with bleeding ulcer unrelated to H. pylori or NSAID should remain on PPI therapy indefinitely given a 42% incidence of rebleeding at 7 years without protective therapy. Coming to Maldives test, it accounts for 2 to 10% of upper GI bleeding hospitalization. The classic history involves vomiting, retching, or coughing preceding hematemesis, especially in an alcoholic patient. Bleeding from these patients, which are usually on the gastric side of the gastroesophageal junction, stops spontaneously in 80 to 90% of patients, and it can recur in only 0 to 10%. Endoscopic therapy is indicated for actively bleeding malarious tears. In this image, we can see malarious tears in the gastroesophageal junction. Coming to esophageal varices, the proportion of upper GI bleed hospitalization due to varices varies widely from 2 to 40%. Patients with variceal hemorrhage have poorer outcomes than patients with other sources of upper GI bleeding. Urgent endoscopy within 12 hours is recommended in cirrhotics with upper GI bleeding. And if esophageal varices are present, endoscopic ligation is performed and an IV vasoactive medication like octreotide or somatostatin or vapriotide or telrepressine is given for 2 to 5 days. And combination of endoscopic and medical therapy is superior to either therapy, along with decreasing rebleeding. And transjugular intrahepatic portosystem shunt is recommended in patients who have persistent or recurrent bleeding despite endoscopic and medical therapy. So if the patient treatment fails on endoscopic and medical therapy, we can go for TIPS. And TIPS should be also be considered in the first 1 to 2 days of hospitalization for acute variceal bleeding in patients with advanced liver disease. That is example like Chaltug class C with 10 to 13 of score. Portal hypertension is also responsible for bleeding from gastric varices in the small and large intestine, and portal hypertensive gastropathy and enterocolopathy. Bleeding gastric varices due to cirrhosis are treated with endoscopic injection of tissue adhesive like N-butyl cyanoacrylate if available. If not, TIPS is performed. In this, we can see esophageal varices. We can see the cirrhotic liver and the dilatation of portal vein and the spleen. Cirrhosis will cause the portal hypertension, which will in turn lead to varices. Varices is nothing but anastomosis of vessels. We can see varices which are present in the dilated dilated submucosal veins. So in acute management of bleeding of esophageal varices, the hemodynamic resuscitation is the primary goal of treatment, followed by giving vasoactive like substances like octreotide, and if still it not doesn't subside, we can go for banding or sclerotherapy, followed by prophylactic antibiotic like ceftriaxone. Coming to the chronic management of esophageal varices, we should start the patient on beta blockers and endoscopic variceal ligation. Erosive diseases are endoscopically visualized breaks which are confined to the mucosa and do not cause major bleeding due to the absence of arteries and veins in the mucosa. Erosions in the esophagus, stomach, or duodenum commonly cause mild upper GI bleed. And the most important cause of gastric and duodenal erosions in the NSAID use, that is 50% of patients who chronically ingest NSAIDs may have gastric erosions. Other potential causes of gastric erosions include alcohol intake, H. pylori infections, and stress-related mucosal injury. And stress-related gastric mucosal injury occurs only in extremely sick patients, such as those who have experienced serious trauma or major surgery and burns covering more than one-third of the body surface area, and major intracranial diseases or severe medical illness, that is the ventilator dependence and coagulopathies. In this, we can see erosions. Other causes of upper GI bleeding are less common causes, which are neoplasms and vascular ectasia, including hereditary hemorrhagic telangiectasias, that is Osler-Weber-Rendu syndrome, and gastric antral vascular ectasia, which is also called as watermelon stomach, and Delphi's lesion, in which an aberrant vessel in the mucosal bleeds from a pinpoint mucosal defect. In this image, we can see a watermelon stomach and Delphi's lesion, pinpoint bleeding site we can see. Coming to the small intestinal sources of bleeding, it accounts for about 5 to 10% of GI bleeding. The most common causes in adults, that is more than 40 years, are vascular ectasias and neoplasms, example GI stromal tumors and carcinoids, adenocarcinoma, lymphoma, metastasis, NSAID-induced erosions and ulcers. Meckel's diverticulum is the most common cause of significant small intestinal GI bleeding in children, decreasing in frequency as a cause of bleeding with age. Other causes in patients less than 40 years include Crohn's disease, polyposis syndrome, or neoplasms. Colonic sources of bleeding. Hemorrhoids are the most common cause of lower GI bleed. Most common cause of lower GI bleed in adults is the diverticulosis, followed by vascular ectasias, especially in the proximal colon of patients more than 70 years, and neoplasms, that is primarily adenocarcinoma. In this image, we can see diverticulosis. Colitis, like it can be due to ischemic or infectious or Crohn's disease or ulcerative colitis, NSAID induced colitis or ulcers. And we can see colonic bleeding in post-polypectomy bleeding and radiation proctopathy. And in children and adolescents, the most common colonic cause of significant GI bleeding are inflammatory bowel disease and seminal polyps. Coming to the approach the patient of GI bleeding, initial assessment of the patient is very important, and when the patient comes to us, the first thing we should do is measurement of the heart rate and blood pressure should be assessed initially, and clinically significant bleeding leads to postural changes in heart rate and blood pressure, and it can cause tachycardia and recombinant hypotension. So when the patient comes to us, we should first measure the blood pressure and heart rate of the patient. In contrast, hemoglobin does not fall immediately with acute GI bleeding due to proportional reductions in the plasma and red cell volumes. A differentiation of upper GI bleeding from lower GI bleeding. Hematemesis indicates an upper GI source and melena indicates blood has present in the GI tract for more than or equal to 14 hours and as long as 3 to 5 days. The more proximal the bleeding site, the more likely melena will occur. And hematochezia usually represents a lower GI source of bleeding. Although an upper GI lesion may bleed so briskly that blood transits the bowel before melena develops. When hematochezia is the presenting symptom of upper GI bleed, it is associated with hemodynamic instability and dropping hemoglobin. Bleeding lesions of the small bowel may present as melena or hematochezia, and other clues to upper GI bleed include hyperactive bowel cells and an elevated blood urea nitrogen due to volume depletion and blood proteins absorbed in the small intestine. And a non-bleeding nasogastric aspirate may be seen in 15% of patients with upper GI bleed who present with clinically serious hematochezia. Evaluation and management of the upper GI bleed. Baseline characteristic predictive of rebleeding and death include hemodynamic compromise, that is tachycardia or hypotension, increasing age and comorbidities. Discharge from the emergency room with outpatient management has been suggested for patients with a Glasgow Plattsford score, possible range is 0 to 23 of 0 to 1 or 0 to among patients less than 70 years, because when these patients are hospitalized, less than 1% of such patients require intervention and less than 0.5% death. PPI infusion may be considered at presentation as it decreases the high risk ulcer stigmata, that is active bleeding and need for endoscopic therapy, but does not improve clinical outcomes such as further bleeding, surgery or death. And the promotility agent erythromycin 250 mg intravenously 30 minutes before endoscopy also may be considered to improve visualization at endoscopy, as it provides a small but significant increase in the diagnostic yield and decrease in the red cell transfusions. Cirrhotic patient presenting with upper GI bleed should be given an antibiotic, quinolone or ceftriaxone, and an IV vasoactive medication upon presentation, even before endoscopy. Antibiotics decrease the bacterial infections, rebleeding, and mortality, and vasoactive medications may improve control of bleeding in the first 12 hours of after presentation. And upper GI endoscopy should be performed within 24 hours in most patients with upper GI bleeding. Patients at higher risk, that is who are having hemodynamical instability and cirrhosis, may benefit from more urgent endoscopy within 12 hours. Early endoscopy is also beneficial in low risk patients for management of decisions like discharge. And patients with major bleeding and high risk endoscopic findings, that is the varices, ulcers with active bleeding, are visible benefit from endoscopic hemostatic therapy. Patients with low risk lesions like clean glazed ulcers and erosions, non-bleeding malrevisitors who have stable vital signs and hemoglobin and no other medical problems may be discharged home. Cirrhotic patients presenting with upper GI bleed should be given an antibiotic. Evaluation and management of lower GI bleed. Patients with hematochezia and hemodynamic instability should have upper GI endoscopy to rule out an upper GI source before evaluation of the lower GI tract. And the colonoscopy after an oral lavage solution is the procedure of choice in most patients admitted with the lower GI bleeding, unless bleeding is too massive, in which case angiography is recommended. CT angiography is often suggested prior to angiography to document evidence and location of the active bleeding. Sigmoidoscopy is used primarily in patients less than 40 years old with minor bleeding. And in patients with no source identified on colonoscopy, imaging studies may be employed. And technician 99M technician web red cell scan allows repeated imaging for up to 24 hours and may identify the general location of bleeding. And in active lower GL bleeding, angiography can detect the site of bleeding and permits treatment with embolization. Evaluation and management of the small intestinal or obscure GL bleeding. In patients with massive bleeding suspected to be from the small intestine, angiography is the small initial test with CT angiography or 99 technician laboratory scan prior to angiography if the patient's clinical status permits. For others, repeat upper and lower endoscopy may be considered as the initial evaluation because second look procedures identify source in up to 25% of upper endoscopies and colonoscopies. If second look procedures are negative, evaluation of the entire small intestine is performed, usually with video capsule endoscopy. However, if capsule endoscopy does not allow full visualization of the small intestine, tissue sampling or application of therapy is indicated, and deep enteroscopy, that is double balloon or single balloon or spiral enteroscopy, allows the endoscopist to examine, obtain specimens from and provide therapy to much or all of the small intestine. If all tests are unrevealing, intraoperative endoscopy is indicated in patients with severe recurrent or persistent bleeding requiring repeated transfusions. Positive fecal occult blood test. Fecal occult blood testing is recommended only for colorectal cancer screening beginning at age 50 in average risk adults, and a positive test necessitates colonoscopy. If evaluation of the colon is negative, further workup is not recommended unless iron deficiency anemia or GI symptoms are present. Thank you.